Hello everyone. It's my privilege to demonstrate how to minimize fluoroscopy during an ablation of a case of a regular narrow QRS tachycardia. It is possible indeed to perform ablation without fluoro at all in many instances of, say for example, Avnrt, right-sided SVTs and even right-sided VTs. There are occasions when we did not use fluoro at all, even in cases of idiopathic left ventricular tachycardia. Today, in addition to minimizing fluoro, I may be able to demonstrate in addition how 3D helps in improving the success rate and outcomes with respect to safety and procedural times. The team here at the Madras Medical Mission Cath Lab includes my colleague Dr. Koti, technical support from Avnrt by Mr. Sabri, and our lab technologist Benjamin and Jayaprakash, and the scrub nurses Joel and Maria. So I would like to show you what is this case. To begin with, the introduction of the case. This is a 15-year-old girl who has recurrent palpitations. She was on a couple of medications. The last time she was on the combination of metoprolol as well as verapamil, which she stopped for the last 10 days. She has had a regular narrow QRS tachycardia, which I am going to show you. The basal ECG also looked like normal, and clinically she has a normal cardiovascular status. Echo is normal. I would like to show you the tachycardia ECG. A 15-year-old girl, the first diagnosis could be Avrt, but well, it could also be Avnrt. It looked like the P wave, the retro P wave is just immediately after the QRS. And if you look at the 12-lead sinus rhythm ECG, can you show that? The morphology of 12-lead sinus rhythm ECG is exactly similar to the tachycardia ECG. So the diagnosis is quite wide open. It could be Avnrt, it could be Avrt. Well, it could also be AT. So this is the introduction, and I am going to be telling you what is that so far done on this 15-year-old girl. We have some accesses all from the right femoral sides. We have a right femoral artery 5 French sheath. In the right femoral vein, we have 3 sheaths. One is for coronary sinus decapole catheter, which goes through the 6 French with the Leo lock system, so that it can hold the catheter very firmly. And then we have an 8 French catheter sheath through which I am planning to place an ablation catheter. And then we have a 5 French sheath through which a pre-shaped quadrupole his bundle catheters I am going to be placing. And presently, through the 8 French catheter, I am going to be placing a pre-shaped quadrupole diagnostic catheter, which is going to be placed in the RV apex. Ours is a Siemens Cath Lab. Okay. We have some monitors here in the front. One, a live for the 2D recording. Okay. And this is the 3D monitor, is a review monitor. And our technical support is sitting on the other side. He also has an equal number of monitors in front. So to begin with, I am going to be placing a 6 French quadrupole diagnostic catheter, which is connected to the system, which is pre-shaped to get into the RV. I am going to be using this through the 8 French sheath, and then I am going to pull this out when I am going to be using the ablation catheter. So I have inserted, once the catheter comes out of the sheath, you will know the course of the catheter on the screen there. Seems to me that this tip is superiorly directed. So, it is getting tracked up. Can you show that? Sabri, you may not gather the 3D presently. I would like to see it in a bigger way. Yeah, so the green is actually the tip. So, the tip is actually looking down. So, you notice on the screen there, the live 2D screen, the catheter is recording the atrial signals. So, I manipulate the catheter so as to get into the RV. So, we got into the RV, and then we notice that there probably is a small signal which is probably right bundle. Looks like it is more apical. I pull it little proximally so as to get some his signal. So, that probably get into the RVOT. So, again I manipulate and pull it. We can use actually we can use two orthogonal views, but because we are all used to in the beginning when we are placing the catheters to use the PA view. So, I have kept the PA view. Sometimes it is also okay to use two views which are orthogonal. So, now we can actually tag the his bundle. You can gain up the RV signals. Any idea why the proximal is not okay? You may rectify that proximal electrode, Sabri, Benji. Okay, so I think they got it better. The RV34 is more atrial, and then the distal one is into the cavity. So, now I am going to be using a decapole catheter, which is 6 French into the Leeuwenhoek sheath, because we can fix this catheter when we get into the CS. It is a deflectable catheter. I am going to be using this 6 French. Once this comes out of the sheath, we will start tracking on the screen. What we could notice on the live screen here is during the catheter manipulation, when we are putting the RV catheter, he has developed a right bundle branch block. I hope it recovers soon. So, I am tracking this. In case if there is a difficulty, we can make use of the route through which you traversed while placing the RV catheter. Now, I may or may not use that guide. It is going quite easily. We can take away the 3D, and then once it starts recording the right atrial signals, I try to get into the his bundle area or into the RV cavity. So, we are still in the RA. What we see there, that I am going to be I am using actually two orthogonal views, one PA, not orthogonal, one PA and the other side the LAO. I am trying to get into the RV. So, that is actually at the HISC. You can notice we induced the tachy as well. Wait, we may not terminate the tachycardia presently. We get into the V. Yes, that is the V. You can terminate the tachycardia. Stop. All right. So, what you notice there is the CS, almost all the electrodes are into the ventricle. I make use of the LAO view. Making a clockwise turn, get out the his 1, 2, 3, 4 signals for a while. In the LAO, I am trying to get the A and a V on the CS 1, 2. The decapole, the distal tip has been brought to the his bundle zone. Now, if I flex it to make it more inferior and clockwise twist, it may seek the CS ostium. So, that is what I am going to be doing. You can notice how is the bend along those electrodes on the CS catheter. If I flex it like that, it becomes more bent and it becomes more inferior towards the apex, and I twist clockwise and try now you see in the CS 1, 2 we are noticing A and a V. Maybe it is trying to seek the CS os, and then I manipulate and then I just get into the CS in that area. That is how I entered the CS. So, it took about 2 minutes to get into the CS. It probably is seeking one of the tributary in the distal, maybe one of those posterolateral vein ostium. The CS 1, 2 is located. Notice that we have two catheters, one in the CS, one is in the RV apex. We may or may not use one of another diagnostic catheter, but in our lab we always use 3 diagnostic catheters, not making use of an ablation catheter as a diagnostic catheter. So, continuing the same tradition, I am going to be using a pre-shaped his bundle catheter now, which is going to be placed with the 5 French sheath, which is on the right femoral vein. That is connected to the system. So, I am going to be tracking it up. Can you show Sabri, where is the catheter? Now, we have already localized the his bundle. So, I am trying to get this catheter there. The pre-shaped his bundle catheter is useful to get into the his area easily. So, by making use of the RAO and LAO, it is quite easy to get into the his. So, that is what I am trying to do it here. You notice that the his bundle catheter is into the right atrium, making use of the PA and the LAO view and a little bit of a manipulation. It is possible to get into the his area. So, that is probably the his area. So, you can take a respiration once. So, this is the placement of the catheters without fluoroscopy. We have got one in the his bundle, one in the RV apex, and one in the CS. What you can notice on the screens here is that in the last 5 minutes, without stepping on the fluoro, we could achieve some good recordings, and we have tagged a few landmarks. One is the his bundle zone. You can see the live 2D signals by the his bundle catheter, and then we have made now the CS catheter as the reference for the 3D map. All these 3 catheters were tracked to those respective places by using abdominal patch as the reference. The blue is in the RV apex, the yellow is the CS catheter, the red is the His bundle catheter. We would like to actually look at the CS ostial zone, but it is approximately what we can consider is the proximal pair of electrodes on the CS diagnostic catheter is in and around the CS ostium. In case if it turns out to be Avnrt, 3-4 times during the manipulation of the catheters, we induced the regular narrow QRS tachycardia, where it looked like a on V. So, it could be very well Avnrt. We are going to be quickly doing certain diagnostics now. Can you induce the tachycardia? Maybe V pacing to begin with. Yeah, you do S1, S2. There was some VA block. 360 Venke back, and it remained concentric. You just do once 400, 300. That is VANERP. Okay. $350. All right. So, it looks like a decremental concentric. You can pace A 500, 400. Pace A 500, 400. So, tachy induced, we can do certain maneuvers. Later on we will see how it how it was induced, but quickly do some diagnostics there. HV is approximately about 45, is a on V tachycardia. He is doing certain maneuvers there. A cycle length of 360. You may do that. Seems to me that there is no influence on that his PVC. All right, you can do a VOD. Okay. So, he is pacing at 330 ventricular overdrive. Yeah, it looks like a few beats dissociated there. Go leftwards. Yeah, 370, that one was pulled. Yeah, okay. Maybe you can slower. 360 you overdrive. That is a VAV there. All right. So, 80 is kind of ruled out. You do one more time VOD at a shorter cycle, lower rate. 370 is also okay. Yeah, so that is clearly dissociated. Stop there. So, proving that it is an Avnrt. Now, we are going to be going ahead with an ablation, and then I hope very safely without fluoro, I should be able to ablate. Yeah, so far we have established the diagnosis. It is almost certain that it is a typical Avnrt. We have caused some kind of a right bundle branch block, which is not yet resolved. Looking at the 3D scan, you notice that the His bundle is moved out of the His bundle zone. We do not really require to be struggling to get into the His bundle now anymore, because we have those critical areas, the His bundle area tagged neatly. So, that is one advantage of the 3D. Now, you do not have to struggle to keep it there, and in my hand is the 7 French ablation catheter, which is bidirectional, is a therapy bidirectional catheter, is a medium curve, which is the routine catheter what we use for typical Avnrt ablation with normal hearts. I am going to be now introducing this into the 8 French sheath. The catheter is connected to the system. The CS catheter is not displaced, as you see in that is very important, because if that is displaced, your critical areas are not going to be valid anymore. Now, I am going to be putting this into the 8 French sheath, and then we track this catheter up. So, on the 3D it starts coming up, you can see that, and then I am going gently, and sometimes it gets into one of those branches of the inferior vena cava, and then once I get into the atrium, I start seeing the good A there, and then the His bundle catheter, I may not require it anymore. I just keep it out of the into one of the A area. So, that is out of the area which we are interested. I have taken this ablation catheter, which shows A. I am making use of the PA view and the LAO view. Try to get into the His bundle area, which I am recording. You can reduce the gain on 5/6. Yeah. So, on the RF12, there is kind of a far field His. Let me just get the His there. So, the area which we are tagged, it is still valid, and the CS catheter, which is reference catheter, which has not moved. So, you have reconfirmed that, and then we are trying to get into the inferior posterior Cox triangle area, which is near the CS ostial zone. So, I flex again, and then clockwise rotate. There is a big V. I am trying to get a little bit of a away from the His, keeping it flexed more into the ventricle, trying to get into the, it is trying to getting into the CS ostial zone. So, that probably is the area which is little superior. I would like to be safer first in the most inferior area, very tiny A. I started getting some junctionals there, which again tells you that this could be a slow pathway area. Now, I can have a view of both the PA as well as the LAO view, and I am seeing that getting the junctional beats once in a while, and I am also noticing that the ablation catheter is stable. Here I think we should be giving first of our burn. Catheter is much stable, occasional junctional beats. There is a little bit of a respiratory movement which could be normal, and we are going ahead because this seems to be really very safe away from the His bundle zone. We are going to give the first burn. Can you start the burn? So, they have put at 50 watts and 60 degrees. All right, on. Very, yeah. I can actually see to it that it is fast, but I am trying to pull the catheter little out, and it is quite stable. And there is no necessity to fluoro here, because you have everything in your view. It is quite slow, stable. Patient is not having any pain. She is very cooperative. And then at about 60-90 seconds, we can usually stop here. 90 seconds you can stop. Yes. So, quite a stable junction rhythm going on. Okay. So, when I lost a little bit of a control, we stopped it. The PR seems to be a little prolonged, or maybe the same. We try to induce. So, what we noticed here that there is so much of a control when we are using the 3D. PR seems to be normal, and you can do that S1, S2. I consider without using fluoro and only concentrating on 3D is much safer. It is just that our mental makeup is that during the ablation we should be stepping on to the fluoro paddle, which is really not required. And that is what I wanted to demonstrate today. What we are noticing here that at 500 and 350, which was easily inducible earlier, there has been no induction so far. There is no suggestion of an AH jump. We will go down till the AV nodal ERP is reached. The girl who used to have easily inducible tachycardia, I do not think I should be putting her on isopril. We had good signals. Within the first few seconds, we had a stable, slow junctional rhythm. I do not think I should be giving her any more burns as well. So, yeah, so still there is AH which is without the jump. All right, so you can stop there. It was supposedly to be a tricky case, a young girl, Avnrt, but then 3D helped us to do the lesions, to deliver the lesions very safely, and we could accomplish this whole case in the 15-20 minutes without using fluoro. Which I consider should be the trend in all the cases whenever it is possible. It is quite safe. Procedural time is probably almost the same, or even sometimes less than the conventional way of fluoroscopy. It is just that the gadgets are required, but then for example, what we use, the Avnrt patches, which could be even legally used for another person because it is not inside the body. So, the cost can be contained. Just a quick recap of what we have done so far. So, this was the 15-year-old girl who had a narrow-QRS tachycardia, which turned out to be a typical Avnrt. In this lab we used the Siemens cath lab, but then as you notice the fluoro screens, they are all black. We never used even for a few seconds the fluoro. And what we see in front of me are the 3 monitors. The central one is the 3D monitor. The right hand side is the live. The left hand side is the review screen. The same set of screens are there for our fellows and the technical support, the same set of monitors including the hemodynamic monitor. What we notice here on the 3D, the red dots are the His bundle location, and then you have a yellow catheter is a decapolar catheter in the CS, which had been the reference catheter, which was fixed on the sheet here with one tegaderm here and one sheath lock, C lock here, so that it does not move. And then you notice that the ablation catheter is still neatly sitting there at the area where I had given the RF lesion, which was about 60 degrees centigrade, 50 watts and about 40 to 50 degrees centigrade. We delivered approximately 60 to 70 seconds there. Within the few seconds, there was this stable junctional rhythm, and we tried few times. The tachycardia could not be induced. Earlier, just a catheter manipulation could have induced. So, I believe this technology is worthy of adopting. Vanita, I thank you so very much for giving this opportunity. It is my privilege to showcase what we do here at the MMM. I hope a few of the people in the audience are inspired enough to do cases using the 3D technology, which is safe, and then we can avoid the fluoroscopy. Thank you, Vanita, once again.